Welcome to Intro Psychology Unit 16. This is our final unit of the course. And in this unit, we're going to be talking about clinical psychology, but rather than discussing the different clinical disorders, we're going to be talking about treatment and therapy. And to get things started off, we're going to talk about the people that can provide us with treatment and therapy, mental health professionals. And so when we talk about mental health professionals, I like to go into a bit of a story about how this area of work has evolved in the last 100 years. Roughly about 100 years ago, most people that would address mental health concerns would work at a hospital and would have a medical doctorate. And so these would typically be just general practitioners or practitioners who had gone on and had a specialty in psychiatry. In fact, when we think about the asylum years, we are typically thinking about medical doctors with a psychiatry degree or psychiatric nurses. And so at the early 1900s, what we were really seeing is people had to go on and learn a lot about the body and a lot about really intensive residency programs in order to become a doctor and then go on and specialize further into psychiatry. What this led to was a very biological-based lens on care, which is okay, but it also made a lot of rigor to get into the stepping stones to being a mental health professional. There seemed to be a lot of gatekeeping, and as we started to learn more in the 1930s, 1940s, there was a need for more mental health professionals than what the medical field could supply. There was a lack of supply for the demand of mental health professionals. Even training psychiatric nurses, whose training was less rigorous than the doctors, it still wasn't completely filling in the gaps. Of course, we have Sigmund Freud, who was a trained medical doctor, but who moved away from medicine and really launched psychoanalysis and started to train psychoanalysts that didn't need to go on and have a medical doctorate. And so then we had this budding area of psychoanalysts. Today in Canada and the US, most psychoanalysts have to have a clinical doctorate, either in clinical psychology as a PhD or a PsyD. In addition, in most states and provinces in North America, you need more than just the degree. You need to have a license to practice as a clinical psychologist. There may be some private schools that still operate as training you as a psychoanalyst, but not a psychologist. Sometimes they're used as two separate words. But for the most part in Canada, we look for clinical psychologists. So in Canada, what we can do to become a clinical psychologist is to get a doctorate in psychology or a doctorate in the philosophy of psychology. Now, both of these are advanced graduate degrees that take quite a long time to achieve. In many cases, you need to have a master's and a bachelor's degree beforehand. And we're also realizing the same thing happened with psychiatry. There's a lot of gatekeeping, and there's a lot more demand for mental health professionals than we can supply through our rigorous PhD and PsyD programs. And so luckily we have other ways to become a mental health professional now. We know that social workers can often work alongside psychiatrists and psychologists. And in Canada, we have some rigorous social work programs that require less years of graduate training to become a licensed social worker or a registered social worker or a clinical social worker. We also offer counseling psychology and educational psychology, which can often be tapped in not through psychology programs in most universities, but in the education programs in most universities. And through getting an MA or an MSc or an MED in counseling from an accredited program, you can also go on to become a mental health professional in that way. It tends to be a little bit less rigorous than getting a PhD, but can still train you with lots of good counseling skills. And we are starting to train people that have a very specific niche area in mental health. For instance, there are some bachelor level programs that focus on training people as behavioral analysts. We'll talk more about what behavioral analysts do, but for starters, basically they work a lot with young children and a lot of people on the autism spectrum to help them with their day-to-day behaviors. The scope of their work is more narrow and less broad than a counselor, a social worker, or a psychologist, but it allows them to go and apply their knowledge to one specific field. And that's still not enough. We know that today we have even more demand for mental health professionals than what we can supply through psychology, social work, counseling. And so now we also train lots of volunteers who are people who help volunteer at distress lines in your community or volunteer at local shelters or at drop-in centers, and it's very important. There still is a lot of gatekeeping though, and we know that there's more people that have the right aptitude and skills to become mental health professionals than are allowed in our graduate programs at times. And so that is something that is a very present criticism we're aware of. We want to be able to train more people and get more people into this field to meet the demand. Now, when you look down at these lists, if you're looking for a mental health professional in your personal life to offer treatment and therapy to you or a loved one, I think it's important to understand that a clinical psychologist, a social worker, a counselor, a psychiatrist, a general practitioner, and your family doctor can all offer you very sound advice. I think it's important to recognize that clinical psychologists, psychiatrists, and social workers are all legally coined terms that you can't call yourself a clinical psychologist without the certain licensing. There's certain accreditations that go along with all of these. However, there are some terms that anybody can call themselves at any point in time. If you look at a mental health professional who calls himself a psychotherapist, for instance, or a life coach, or just a therapist, those are not legally regulated terms. And so if you're looking at someone who calls himself a psychotherapist, that does not mean they meet the accreditation credentials for any of these types of work. And so like a psychotherapist is where you might get someone who maybe has a couple bachelor level degrees, or they have life experience that they feel informed, and the care they give could be good, but it's not guaranteed to be good. So just something to be wary of when you're looking for a mental health professional in your life. Now, regardless of what mental health professional you're working with, many of them work alongside each other in community clinics or in hospitals, and they can make up a rounded team of lots of different care providers. And the type of care they can provide can vary along certain modalities. We know that you can have really good mental health care that is focused at the individual level. You can have one-on-one therapy, or you can have it in a group setting where many people with the same concern, perhaps an addiction or an anxiety disorder or schizophrenia, can all meet together and can hear about each other and support each other, and that's supervised by a professional. You can also have couples or family therapy, and this is when you're not just focusing on the individual now, but you're focusing on the relationship and the dynamics within a family or within a couple. And whether you're looking at individuals, groups, or families, you can also deliver this either in person or by telephone or online. And we know in the last year or so, the mode of online therapy has really greatly expanded. It's been around for a few years already, but now that we've had to evolve due to the pandemic, it really has evolved. So you can reach therapy in lots of different modalities. And one of the things I want to emphasize here is you can get absolutely great care in any of these. So you can have great care through the phone or online, and group therapy can be exceptionally awesome, especially for someone who is worried about that one-on-one dynamic. Now, for the purposes of this unit, we're going to go through lots of different types of approaches to treatment and therapy. We're going to be starting off talking about the biomedical approach. And when I talk about the biomedical approach, this is going to include medications as well as brain stimulation. And I'd like to give a little bit of a historical overview of how this has evolved. We talked about in Unit 15 about how our humane versus scientific, our treatment plans and our approaches to mental health has evolved. And it really does start with biomedical stuff around the late 1880s and in the early 1900s. This is really when the medical model started to evolve, and we started to discover that some types of mental health concerns were actually related to the body. We know that an infection like syphilis, although it starts off as mainly affecting your body, if it goes untreated, will actually lead to the decay and deterioration of your brain and your brain tissue. So that was really when the connection was found, was around 1900s. We can see that some biomedical techniques like the EEG, electroencephalogram. Now, you don't need to know these techniques in detail if you didn't take Psych 200, but for those of you who did and you know what these terms mean, you might be interested in knowing that the electroencephalogram was really started to be used popularly around the 1920s. Brain lobotomies in a professional clinical setting started to be used in North America and Europe around the 1930s. We know that electric shock therapy started to be used shortly thereafter. And then we have some medications coming online, with lithium being used in the 1950s, a common anti-anxiety medicine known as Valium being used in the 1960s. We also found our brain imaging technology of MRI started to evolve in the 1980s, and with antidepressants like Prozac kicking off in the 1990s. We've had lots of other milestones since then. Now, you don't need to memorize these milestones, this is just for your own interest, but I wanted to show you sort of how the biomedical model has evolved. We can also layer this on top of another approach we'll be talking about in this unit, which is really the psychodynamic or psychoanalytic or Freudian approach. And we can really see that although Freud started working in the 1890s, his popularity really peaked when he went on tour in America around 1910. And that's rapidly when lots of care that you could find when you went to a mental health professional started to change. It wasn't necessarily biomedical, but the talking cure and psychoanalytical insight therapy really started to become popular. It's still around today, but it's less popular than medications. But you can definitely find, especially in Canada, some care providers who will offer you some psychodynamic therapy. And so those are just some key highlights. Again, you don't need to memorize them. Another type of approach we'll be talking about is behavioral approaches to treatment and therapy. And although Pavlov and Watson were around the early 1900s, it was really after Skinner that things started to really peak. It still definitely is popular, but we tend to use it in non-clinical settings as well. Definitely behaviorism is huge in the autism community, it's huge in education, it's huge in parenting. But nowadays, when you go to a clinical office and you go and you're in mental health crisis with a disorder, behaviorism is not the most likely treatment that you will receive. Instead, one that tends to be combined with behaviorism and uses a lot of behaviorism in it is cognitive behavioral therapy. And so we can see this roaring in popularity, quickly becoming the most popular type of mental health care. It starts to go downhill after the mindfulness really starts to emerge, and that's with valid criticism, mainly brought upon by dialectical therapy and Marshall Lyman. We'll talk about dialectical therapy and how it's more recent to emerge in the 1990s. And then the last one we're going to really talk about, it's actually two, but I connect them. Not everybody would connect them. And this is the idea of humanism or positive psychology. And so what's really interesting here is it kind of rises right up in the 1950s. Rogers starts working in the 40s, but his popularity really peaks in the late 50s, 60s. It stays really popular until cognitive behavioral therapy becomes popular. That's what kind of drowns it out. And so it goes down, but right when cognitive therapy, the pink line goes down, the red line starts to go up again. And so this is when Martin Seligman really starts to promote the idea of positive psychology. Not everybody would consider humanism and positive psychology on the same thread, but it's a thread that I like to connect. Now again, you don't need to memorize this, but I just wanted to give you an overview of how the biomedical, psychodynamic, behavioral, cognitive behavioral, dialectical, and humanist and positive approaches to treatment can vary. So right now we're at a time where when you go to a clinical psychologist, you're more likely to receive CBT in Canada. You can definitely get access to medications. Hopefully there's a lot of humanism in there. And if you go on special wait lists, you're probably going to have access to dialectical, behaviorism, just pure behaviorism, less common. And psychodynamics still does exist, but it's probably harder to find. So it's interesting to see how these will evolve over the next decade or so.